So I am a gastroenterologist, and I work with nutrition and nutritional support, and I had the privilege to work with amyloidosis patients for their nutritional support. So what I'm going to talk a bit for the next minutes is a bit about healthy eating and lifestyle, and why it's important to take care of nutrition and to follow nutrition in patients with amyloidosis. How cope with digestive symptoms, because in some patients the GI tract is involved, so they might have different symptoms, variable symptoms, and we can help a bit with these symptoms as gastroenterologists. And also some words on the dietary management during treatment. So it's important to remember, even if we have to go through certain therapies, we have symptoms, that we still have recommendations about healthy diet and lifestyle. This is the famous pyramids that we have, with at the base of the pyramid we have hydration and a lot of fiber, so it's fruits and vegetables, and then the second part is carbohydrates, and mostly also with fiber. And then we have the proteins with the milk products, the fish, the chicken, some meat. And at the top of the pyramid, we have all the fat and the sweets and everything that is what we call empty calories, because it's not very useful. The only diet that has been shown to be have a positive impact and decrease mortality, this is with very good, very long cohort studies that were done the past years, is the Mediterranean diet, where we will find the previous baseline with the whole grains, the legumes, and the vegetables, fruit and vegetables. But in the protein part here, we'll have a lot more fish, some nuts, which have the omega-3 that we like, and the meat finally is up there with the red meat is up there with the sweets. So very rare portions of red meat during the month. And also the Mediterranean diet, we know that is also the secret is the olive oil, and also probably the social moments, the together time, and maybe the one glass of red wine per day with the antioxidants. Also, fluids are very important. Fluid hemostasis. We know that we have to. We don't drink enough, probably, but we have to have the water intake should equivalent to the water output. And of course, this for patients with maybe involvement of the heart, of the kidneys, of the liver, this amount has to be taken into consideration. But this is also very important. So these are the recommendations of the USDA 2020 about healthy living, and so this was based on what is going on in the US now. So first recommendation was to limit beverage with added sugar, so all the colas and the soft drinks and everything, and drink more water. To limit salt, less than 2 grams per day. And to eat a diet high in fruits and vegetables. We talk about a lot of the rainbow diet, a lot of colors. This is something that can help you really put all the vitamins, the antioxidants, all that we need in our diet, just by having many colors. So you have the red peppers, you have the green, you have the yellow, the orange, the carrots, a little bit of gray, the fish. So we have all the vitamins in a rainbow diet. We limit red meat and processed meat. And we prefer fish, lean meat, and plant-based proteins. Choose whole grains and limit alcohol. So this is for the general population, but it still remains important for everybody. So what we will focus a bit on why nutrition is important for patients with amyloidosis. Why do we have to follow it up? So we know that it can involve many different organs. And the symptoms are very different. This is a recent review in the New England Journal of Medicine that just came out this week. It was very convenient for me. But there are studies that show that it's important that nutrition plays a role. So they had a cohort, this is over 10 years ago, a cohort of 110 patients. They have some special criteria to see that their 66 patients were malnourished based on previous weight loss, on the body mass index, which is the body and the height, and we see that the body mass index, if it's less than 22, less than 20, depending on age, it means that there is malnutrition, and also some clinical symptoms as if there are low proteins in the blood or edema. So 66 of these patients were malnourished. So already we know that it's frequent. Another study that followed wanted to see how was the outcome of these patients depending on the degree of malnutrition. So these are patients that have cardiac disease, 128 patients, and they considered two elements that can suggest there was a malnutrition, so the low body mass index, as I explained, and previous weight loss. And according to this criteria, in patients who were equivalent on the heart involvement stage and response to treatment, well, they had different outcomes. So patients who were malnourished patients who were not malnourished had a better chances to survival, as you see in these curves here. So it's important also to prevent malnutrition, to have also a good response to treatment. And how can we do that? Is there something that may work? So this is the same Italian team. They assessed the intervention of nutritional counseling with a dietitian, a systemic way. Every I don't know exactly the timing, but it was regularly done with having a dietary approach, giving some advice, and trying to also integrate nutritional support by complements or even medical nutrition therapy if there was malnutrition despite the first steps. So the patients were randomized meaning that they were randomly assigned to nutrition counseling or standard, meaning they were followed by their healthcare practitioners without a dietary intervention. And they finally saw that the nutritional counseling group had a better energy intake, so they ate more calories, had less weight loss, so they preserved their weight, and better quality of life because they also filled up some questions about the quality of life. And finally, also, they had a better survival. So this is important evidence that supports the intervention of a dietitian during the treatment and the follow-up. So what can a dietitian do? So advise and really give a personalized dietary prescription, because if you get some advice but you really cannot adhere because you don't like the foods that are advised for you, well, maybe it'll not work. So there's no one size fits all. So this is the role of the dietitian, really to manage to make a plan together to have a better adherence and that everything works the way we want to. So based on personal eating patterns, to satisfy the protein calorie requirements. And also with the different organs that are involved, we have to pay attention and to restrict or increase the specific nutrient components, such as the proteins, fluids. We know that in some cases of renal involvement, you might need less proteins to preserve a bit. Patients that have heart failure might need some fluid restriction. So this has to be taken into consideration. They start working with regular foods, maybe enriching these regular foods to get a bit more higher energy density in these foods. We might give some oral supplementation, which is the ready over-the-counter supplements that we can buy in a pharmacy. And if necessary, we'll give medical nutrition therapy if required, meaning that nutrition with a tube feeding, or even parental nutrition via a venous access, which might be required in some cases. So how can we deal with digestive symptoms? Regarding the sphere that I deal with, the digestive sphere, we will have involvement of the liver. So the symptomatology will be a very big liver that's very enlarged that we can feel when we examine the patient, and where there is really the liver doesn't function very well. It causes resistance to the passage of fluids, of the venous congestion, and you will have ascites, which is the belly that's full of water, as you see here, and also jaundice, because the bile accumulates and you have the yellow eyes and the yellow skin. And you have the infiltration of the digestive tube, and this can also have different infiltration rates. So it can touch the mucosa, which is the inner part where you have the absorption. It can touch the muscles that are a bit more deeper, but surround the mucosa and are important for the progression, the contraction of the bolus. They can touch the nerves that are also important for the coordination of the contraction, and the vessels that will bring the blood to the gut, to the intestinal tract. And according to the infiltration and the location of the infiltration, we will have different symptoms. So if we have the mucosal involvement, so if the mucosa is infiltrated and it doesn't work, we will have malabsorption. So this can be a very complex presentation, because patient will have diarrhea, we will lose weight, and we'll have multiple vitamin deficiencies according to what may be decreased. And this can range from having vitamin deficiencies like vitamin B12 or iron, where you have anemia, or you can have vitamin K, where you have bleeding problems, and you have bluish discoloration whenever you touch a rough surface, or you may have protein malabsorption, and you have edema, like the edemas here in the feet here. This is probably the easiest way to diagnose, because we can go with an endoscope and make biopsies. So it's quite easy finally to have a little piece and to send it to the pathologist and see that there is infiltration due to amyloidosis. So we have to stay focused as physicians to detect all these deficiencies and to be able to supplement them if necessary. Another involvement is the muscular involvement, and there we really have problems with contraction of the gut. And this can give constipation and bloating. Sometimes it doesn't move at all, and you have all the bacteria that will have overgrowth, and you have what you call SIBO that will accentuate this bloating. And this can lead up to what you call pseudo-obstruction, meaning that there is no occlusion in the gut, but everything is dilated, nothing is moving, and we might find the patient literally with a big belly like this. There's no fluid in it. We might think that it's ascites, like the liver involvement. No, this is air. It's blocked air because nothing is moving, and this can be terribly uncomfortable and not really easy to have a solution. But this is where we might get involved as gastroenterologists and nutritional experts. Again, because of the infiltration of the muscle, you might have what we call gastroparesis, which means that the stomach doesn't empty. We know that the stomach has a different emptying rate according to what is inside of it. So if you have water or a little bit of sugar in the water, it will empty quickly. If you have had a high-fat meal, it will take more time. This is even in normal people with a normal gastric emptying rate. But if you have gastroparesis, in this case, you will have more symptoms if you have a high-fat meal or a solid meal instead of a liquid or a high-calorie and low-fat meal. The nerve involvement also will translate in some coordination deficiency, again with constipation, with nausea, vomiting, pain. In the vascular involvement, you will have what we call ischemia, meaning that the blood doesn't get to the gut, and there is bleeding, and the mucosa gets a bit ulcerated. It means that it's kind of like falling apart, and this also can be quite severe. As I said, that it depends a bit also on the location, the different symptoms. So esophagus, you might have reflux and heartburn. You might have dysphagia or difficulties in swallowing. And then sometimes the food might get blocked because the esophagus is infiltrated with the amyloidosis. If it's in the stomach, it's the distension of the gastroparesis, as I explained, and also abdominal pain. The small intestine, it's really the malabsorption, the diarrhea, the weight loss, and pseudo-obstruction. And the colon is mostly also problems of the transit, diarrhea, constipation, or incontinence. So we have we can try to confront these symptoms either with some lifestyle advice and dietary advice or with medication. So for the reflux, we try to avoid heavy meals and some specific foods like acid foods. And patients finally are very good at identifying the food that's problematic. And avoiding it formally. Fatty meals, as I said, will probably increase the reflux as it will decrease the gastric emptying. Try to avoid drinking fluids during the meals is probably might help, because sometimes you might not drink well during the day, you're thirsty, you eat in the evening, and then you drink maybe a liter in the evening with your meal, and this will really increase the content of the stomach and give more reflux. We try to sleep a bit with the head up and not completely flat, and antacids can be helpful in these cases. As gastroparesis, which is the delayed gastric emptying, again, small and frequent meals, not very high in fat. Eating slowly and chewing well may help, and then prokinetics that will help a bit the motility of the stomach. For diarrhea, if there's no severe malabsorption, we can manage the symptoms with loperamide, Imodium, giving more proteins and decreasing a bit the fibers, despite that it's well put down at the base of the pyramid. And if there is a concern for SIBO, we might give some short periods of antibiotics. And finally, for constipation, hydration of fibers will help with mild laxative and special physiotherapy to get everything going. So sometimes we really, by doing all these and giving some compliments and dietary advice, we still are in front of a patient that's losing weight, that's weak, that cannot get on with his daily activities or cannot confront his treatment. So we need to give what we call medical nutritional support. And we have, after the first steps, as I said, it was reaching the food, dietary advice, and the complements. The third steps are enteral nutrition. So this is the tube feeding that we put a special compound that has the proteins, the fats, the fibers, the amino acids that are needed, the glucose, as well as the fluid.
I think we have to speed up.
Okay. And
for questions.
Okay, yeah, I'm almost finished. And then the parenteral nutrition, that's through the vein. So this is with the venous axis. We had a patient that we needed to put the parenteral nutrition through the vein because she had this pseudo-occlusion, very severe. And we also put a gastric tube to let out all the air. And she managed to live with that for quite many years, undergo treatment, and of course be at home with her family. So just some last slides about treatment. We know that all the treatments can give a decrease in immune defense. So in this case, we might need to adapt the diet that we give. A neutropenic diet is very limited, and finally it might lead to nutritional deficiencies because it's so limited. And so now we know that maybe it's not really necessary, a very strict neutropenic diet. It doesn't have any impact on infection and mortality. So finally, a well-balanced diet with reduced risk of germs is enough. These are the advices that our dietitians give to really have well-cooked food, avoid raw foods, leafy salads, everything that you might find germs in, even if you wash, and to follow the basic advices of hygiene with washing the hands and everything. So just to finish, a healthy lifestyle with balanced diet and physical activity. It's important as healthcare professionals to prevent malnutrition. That's why dietitians are very important. How to cope with GI symptoms, your gastrologist can help you. We might need medical nutrition therapy, and parenteral nutrition in this case helped. And again, for treatment, dietitians should be involved to better take care of our patients. Thank you.